Hello, everyone. Good morning. Good afternoon. Uh, if you can hear me, just give me a thumbs up. Perfect, perfect, perfect. See, I think I'm just seeing six people on the webinar.
I think, Joy, you're seeing the panelists. There's 7 panelists and 7 attendees.
Attending. All right. Perfect, perfect, perfect. All right. So I think we can actually go ahead and start kick it off. So good morning, good afternoon, everyone. Welcome to today's capacity strengthening session on setting mandatory salt limits on food categories. Recall we had the first QA partners through another phase of information sharing and learning experiences. Our objective today is to share policy goals, country experiences for sodium reduction target policies, and also to comprehend the rationale behind the establishment of sodium reduction targets at the global and regional levels. My name is Joy Amafa, and I'm the Nigeria coordinator for the food and nutrition programs at the Global Health Advocacy Incubator, GHAI. And we currently run 2 active campaigns in Nigeria under the food and nutrition portfolio, where we're supporting advocates, efforts of local partners advocating for mandatory salt targets on food categories, and also on our other program, increase on taxes for sugar-sweetened beverages to discourage consumption and to discourage consumption of these harmful beverages. So I'm excited to be your host today, and I will jump right into the agenda and call on Hema Kachendani, our director for the cardiovascular health program at GHAI. Hema's leadership and guidance over the years have been pivotal to all of our successes in country, and so we're really grateful to Hema for all that you do on the program. So I'll hand it over to you, Hema. Thank you so much.
Thank you so much, Joy. And hello, everyone. I will be very brief. I'm really pleased that we are kicking off today with this lovely webinar. We are very, very grateful for our experts who are joining us. Nadia, who is our recent team member of the research team, has really kind of taken the reins on this. So I want to thank Nadia for this. And of course, we're going to introduce Eduardo as well. But I just wanted to thank you all for joining us, and we hope to have many more opportunities of information sharing as we move forward. And so please don't hesitate to reach out as and when you have questions, but thank you so much again. I'll stop there. Over to you, Nadia. Or sorry, Joy.
Yes, thank you, Hema. Thank you so much. And so the next on our agenda, I will be calling on Dr. Jerome Mafeni. And Dr. Jerome is a senior and technical advisor with one of our local partners, the Network for Health Equity and Development, who will be taking us through the Nigeria country context for sodium reduction. So over to you, Dr. Jerome. Your slides are up, and you have 10 minutes, please. Thank you.
Yeah, sorry for the delay. It took a while to be promoted to panelist. So it won't be a long presentation. And essentially, we are going to be talking about the Nigeria context for the program. I'm hoping that I can move these slides remotely. It doesn't seem like I can from here, so I don't know whether I have to do it from my own screen. Okay. Will you be moving it for me, Joy? I don't know. I don't know who has control of the. I don't know who has control
Nadia
of
will be
the.
doing that for us.
Okay, Daniel will do it. Okay.
Thank you.
All right then. Yes. So basically, just a brief presentation to give some of the context to the work we're doing on sodium reduction in Nigeria. So this is just the outline of the presentation. We'll talk a very brief background, some of the activities that have already been ongoing or are going on as part of the work that we do in terms of the policy arena, our current interventions in this area, and who are our major stakeholders. Next slide, please. So Nigeria is not very good at keeping data, but the data that we have to date will indicate that Nigerians love salt, and our average salt consumption is more than twice the globally recommended level at 10 grams per day. And that's quite high. And so it's no surprise that we're having all the non-communicable diseases, particularly cardiovascular disease spike happening in our population. Apart from dietary salt, which is the main source through which we get salt, we also get plenty of sodium consumption through sodium glutamate from all the cubes and supposed spices made with sodium glutamate that are very popular for spicing our foods. Of course, we all know that high salt consumption leads to high blood pressure, particularly in adults. And what we're doing in the campaign, next slide, is essentially focusing on salts in commercially produced products where we think the salt concentration is really high. And we're hoping that by getting industry, particularly to reduce the salt concentration in their commercial products, we'll be able to bring down the amount of salt consumed by the populace, and so therefore also bring down the figures for non-communicable diseases in the country. In terms of policies, Nigeria put together a couple of years ago a national multi-sectoral action plan for the prevention and control of non-communicable diseases. And some of the key highlights of that plan were to ensure that there was sodium reduction in the country, including setting mandatory limits for packaged foods, basically mandatory limit for industry. And these are supposed to be complemented with mass media campaigns to promote healthy eating and healthy living, and also specific regulations for the food and beverage industry, especially as it relates to advertising for children and adolescents, as well as school-based health education program. Next slide, please. Recently, I think towards the end of last year, Nigeria also put together a new policy on food safety and quality, which we'll talk about briefly. But prior to that, there were existing regulations on food grade table salt, which largely spoke to salt iodization, and it's one of the regulations we're thinking we will be working with NAFDAC, our regulating agency, to update and expand to address the issues around sodium reduction and salt targets. There's also an existing draft legislation on food safety and quality, which is still passing our national legislation. We're not very certain yet when that will be passed, but we're hoping that will be passed within the next year or two, at least within the lifetime of this current National Assembly. Next slide. So when we came on board, one of the early things that we did was to collaborate with the Federal Ministry of Health and Social Welfare. And one of the early things that we worked on was the new policy of safety and quality, which we'll talk about shortly. The other thing that we're trying to do as NHED is to also build a civil society coalition, and I'll talk about that as we go along, so that we can increase our voice and reach out to more persons, particularly key influencers in government, for timely action, so that the appropriate policies and regulations can be enacted and enforced, so that we can protect, our populace. The CSOs will also be working along with us as we try to promote increased media engagement and public awareness, so that the populace is also aware of the dangers of high salt consumption, so that they also on their own can take personal action to protect their health. Next slide. So we've talked about some of the things that we've done. We've worked with the ministry on the new policy, and through the work that we did, that new policy has been passed, signed into law in the last month of 2023. And now, next slide. Now we are working with them to put together guidelines from that policy that will speak specifically to salt reduction targets. And for this, we are continuing to provide technical assistance to the ministry, as well as working with them to develop both advocacy and communication materials, as well as technical materials for their various technical working groups, as well as provide support to their designated consultants for developing the guidelines to ensure that all the material technical elements that are required in those guidelines are put in place as precursor for the work that we shall be doing with NAFDAC to expand their existing regulations on salt and sodium reduction. Next slide. With regard to civil society, as of today, we have about 22 different organizations signed up from a broad spectrum of organizations that includes both in-country civil society organizations as well as international non-governmental organizations, academic institutions, network of professionals, and we intend to continue to expand this network so that by the end of this year, 2024, we should have grown that network from the existing number of 22 to well over 50. And we hope that will continue to be a vibrant network that will really bring to national prominence the issues of sodium reduction and its dangers to societal health. Next slide. Who are our key stakeholders? Of course, is the Federal Ministry of Health, now rechristened Federal Ministry of Health and Social Welfare. And now we have a coordinating minister, as well as, of course, the Minister of State, who is like the assistant minister in this regime. And they, of course, supervise the National Agency for Food, Drug Administration and Control, NAFDAC, who are the main agency mandated by law to regulate all food and food products within the country. And they're the ones who'll be working with to put in place an expansion of their existing regulation, or if they so decide, work with them to put together a fresh new regulations that speaks to salt reduction targets. At the moment, there is a national salt study team that has been carrying out studies on salt, long-term prospective studies that have started quite a number of years ago, and accumulating lots of data, national data related to salt consumption, including the salt consumption patterns, which foods are most consumed in what parts of the country, and what types of alternatives can be used for salt from within local products, etc. And they also are part of our coalition, and we're working very closely with them to use the data that they are harnessing to inform our advocacy. The Ministry of Justice, of course, has been our partner for a while and will continue to be our partners. We're bringing them on board quite early to also begin to understand what we're trying to accomplish, so that by the time both the policies and the regulations reach the Ministry of Justice for formal gazetting, they themselves will not hesitate to expedite that process so that there isn't any undue delay. Of course, we also have our co-grantees, CAPA, Corporate Accountability and Public Participation Africa, whom we're working with very closely and who tend to be more like our media leading partner, helping us to engage better with the media, both print and electronic, the main media, as well as social media. We're also partnering with international organizations like the World Health Organization. We're hoping to bring UNICEF more on board. We're working with RTSL and GHAI in country. And like I said, we plan to continue to expand our partnerships and our key stakeholders to ensure that the issues of salt do not fall on the back burner of things that are not seen to be national priorities. So next slide. So essentially, we think that it's important for us to continue to address the high risk posed to the population by excessive salt consumption, using and mobilizing, efforts from all key stakeholders, because we think that by fostering collaboration multi-sectorally and increasing public awareness, so that the public is also aware on their own to make the right choices, will be able to not only protect the health of the populace, but will also reduce the amount of monies the government will need to invest in trying to take care of the health of people who have non-communicable diseases. So that essentially is the picture, and I hope I've been able to paint a picture of where we started, where we are, and where we're going. Thank you, ladies and gentlemen. Next slide.
Thank you so much, Dr. Jerome, for the excellent presentation and overview of the Nigeria context when it comes to sodium reduction. And that was really interesting to learn. And then I will hand it over to Nadia Flexner, who will be speaking on policy goals and country experiences. Nadia serves as our Associate Director for Research for the Food and Nutrition Programs at GHAI. And in this role, she provides technical support to our country partners to ensure that the most recent and policy relevant research is brought to bear on policy advocacy campaigns. Prior to joining GHAI, Nadia worked as a nutrition policy consultant at the Pan American Health Organization, PAHO, with the World Health Organization. And there she provided technical support to member states for the adoption, implementation, and monitoring of various food and nutrition policies, including breastfeeding, complementary feeding, adolescent nutrition, eliminating trans fatty acid from the food supply chain, and strategies for reducing sodium intake, front of pack nutrition labeling, and applying social marketing for public health issues. Nadia has extensive expertise in dietary assessments, nutrition profile systems, and the use of simulation modeling methods to estimate health and economic impacts of food policies. Nadia also have been leading this effort for the capacity strengthening session. So thank you so much, Nadia, for ensuring that we have this today, and I would hand it over to you. Thank you.
Thanks so much, Joy. Well, let's get started. Let's see if this cooperates. Okay, so today I'll be discussing some cost-effective policies to reduce population-level sodium intake. So the WHO recommends reducing sodium intake to reduce the risk of hypertension and cardiovascular disease, as it was mentioned before. So the recommended daily intake in adults is of less than 2 grams of sodium, which is equivalent to 5 grams of salt or a teaspoon of salt from all food sources. So accordingly, in 2013, all member states committed to the goal of a relative reduction of 30% in population sodium intake. So these are WHO best buys or most cost-effective policies to reduce population-level sodium intake. We have reformulation of products through sodium reduction targets, front-of-pack labeling, also public food procurement and services policies, behavior change communication and mass media campaign, and policies to protect children from marketing. So, as mentioned, food reformulation is a WHO best buy or cost-effective intervention. So food reformulation can be defined as the lowering of levels of critical nutrients in packaged foods while maintaining flavor, texture, and shelf life. So the purpose of this policy is to reduce the sodium content in processed foods through different targets for each food category. So it's specific to each food category. And of course, taking into account the technological feasibility of compliance. So in 2021, in 2021, WHO launched the global sodium benchmark for different food categories, setting sodium maximum limits for 58 food categories. In the same year, the Pan American Health Organization also updated and expanded previous regional targets, and we're going to hear more on how was the process from Eduardo. And then here we have some examples at the national level. For instance, these countries have mandatory sodium reduction targets. So Argentina established sodium reduction targets for 18 food categories, Colombia for 59, and South Africa for 13. In Canada and the UK, which they have both voluntary targets, they set targets for 117 and 85 food categories respectively. So this is, in this slide, I just want to summarize what will be the steps to set mandatory sodium reduction target policies. So first of all, we have to establish policy goals. And what does this mean? This means to assess dietary patterns, main sources of sodium in the diet, and sodium levels in foods. As we heard from Dr. Jerome, these are some activities that has been accomplished in Nigeria and will accompany these process of SAL targets in the country. Then as a second step, it's to select the policy scope. So are we going for a comprehensive model or for a limited model? And what are the differences? So a comprehensive model will capture more major food categories of packaged foods, and a limited model will capture the key food categories that contribute the most to sodium in diets. And then we have to set sodium reduction targets in step 3. And what does this mean? So we collect and analyze the food supply data organized by food category, set sodium target approach. So the approach is going to be a maximum, an average, or a percentage. Most countries have implemented maximum sodium targets. And what this means is that in a food category, there's a maximum limit for the food category as a whole. In an average, on the contrary, it's an average sodium level within the food category. And with this, you have, low levels and high levels as well. And this has been kind of hard to monitor in time. And then the other approach, which is percentage, it means that, governments can say, we want to reduce 20% in sodium levels in bread. So there's a percentage applied to a specific food category. And lastly, we will set timelines, ideally in a stepwise approach. And we can use global or regional sodium benchmark as a reference and adjust as needed according to national context. So targets are usually set at 100 milligrams of sodium per product. And then as a step 4, coordinate and organize a transparent and free of conflict of interest public consultation on SAL targets to evaluate specifically the technical feasibility of the targets with the participation of government, academia, civil society, and industry. Then we want to incorporate these targets in a regulation or law, so they're mandatory. And lastly, we would like to monitor and enforce the SAL targets law. And this will be, to establish an independent and transparent monitoring system. Ideally, to have these results, make it publicly available and use regulatory authority to penalize non-compliance. So these are a couple of examples from two countries taking different approaches. In the UK with voluntary targets and the Argentina with mandatory. In the UK, they're kind of like the first ones in implementing these comprehensive sodium reduction targets for 85 food categories and in different stages. The targets were not the maximum, but were the average salt levels in each food category. And they saw reductions in 10 years, as you can see here, salt intake reduced by 15%. And one of the reasons for this success was that strong government commitment and potential for regulation as well. There were conversations about that. Also industry engagement and cooperation, and other complementary actions like labeling and campaigns. Unfortunately, in 2011, after public health responsibility deal, the progress was lost and annual reductions in salt intake slowed significantly, which, this is the nature of a voluntary approach. In Argentina, they started with a voluntary targets and a strong commitment from government in 2009. There are some studies that show that sodium levels in bread decreased 18%. And finally, in 2013, mandatory maximum salt limits were established for 18 food categories. And so far, the evidence says that there's high compliance with these targets. And there was also a reduction in sodium intake of 18% in time frame of 4 years between 2011 and 2015. And currently, the government is trying to strengthen these targets. So here, I just wanted to show you an example of sodium levels in instant noodles in Asia. From these 3 different countries, you can see how some reduction has been observed throughout the years, but still there are far to comply with WHO benchmarks for this food category. Okay, so moving to front-of-pack labeling, which is another policy that has been recognized by public health organizations as a cost-effective policy to promote healthy diets. So this policy and the purpose of this policy is to identify products that are high or in excess of nutrients of public health concern, such as sodium. And under front-of-pack labeling, how do we define which product will be subject of displaying a front-of-pack labeling? Well, this will be informed by a nutrient profile model. A nutrient profiling is the science of classifying or ranking foods according to their nutritional composition. So this allows comparison between foods when some nutrient levels are high and others are lower. And as you can see in this figure, we can determine foods that are less healthy or healthier by applying rules or operations that are defined by a nutrient profile model. So nutrient profiling will underpin many policies and regulations, such as health claims, restricting marketing to children, school food programs, taxes or subsidies, and front-of-pack labeling. So we can see how here the difference, right? In salt targets, we have thresholds by food category. So they're specific for food category. In front-of-pack labeling, we have one threshold usually for the whole food supply. So this figure illustrates the pathways through which front-of-pack label policies influence the consumption of products high in nutrients to limit, such as sodium. So the purpose of the front-of-pack labeling system is to provide consumers with clear and easy to understand nutritional information, and to indirectly, as you can see here, motivate the food industry to reformulate food products. And this in turn will help consumers in making healthier choices, which has an impact on diet quality and ultimately resulting in health improvement and potential healthcare cost savings. So in recent years, nutrition labeling has expanded. We can see here either in a voluntary or mandatory basis and all the policies that have been implemented so far. So as I mentioned, in recent years, nutrition labeling has evolved as well, moving from just informational labeling to interpreted label. So in this table, I just want to show some examples of different front-of-pack labeling systems. These are classified as informative labels displaying information only, or interpretive labels, which provides judgment on a set of nutrients. So there is a large support for an interpretative front-of-pack labeling from many public health organizations, which agree that interpreted front-of-pack labels are easiest to understand and most useful in consumer comprehension. So for instance here, the evidence demonstrates the mandatory measures have proven to be more effective than voluntary ones. For instance, here we can see initial evaluations of countries adopting a mandatory high-in or excess front-of-pack labeling approach, which show a decrease in the proportion of foods and beverages displaying a front-of-pack symbol after implementation. This is an example from Chile to the left, where after a year of implementation, the proportion of products displaying any warning label decreased from 51 to 44%. In contrast, evaluations of the voluntary health star rating system implemented in Australia and New Zealand in 2014 found low levels of label adoption, with only 23% in New Zealand and 31% in Australia. Also, most products were more likely to have the labels for healthier alternatives that will rate from 4 to 5. So clearly benefiting products with healthy nutrient profile models. Therefore, many countries are favoring mandatory approaches. Also, a national level survey showed that a year after implementation of the Chilean law, a considerable proportion of participants declared choosing foods with fewer high-in symbols after comparing labels, and this proportion will increase over time. So with all these promising results, what would be the potential effect on food purchases? In Chile, evaluations of phase 1 of the policy shows a decrease in purchasing of high-in labeled beverages by 24% compared to expected purchases based on pre-front-of-pack labeling trends. Another study examined changes in the calorie, sugar, sodium, and saturated fat content of food and beverage purchases after a year of implementation of the law, and they found significant declines as well. And we expect greater changes because the implementation of phase 2 and 3 had more stringent thresholds. Okay, so summarizing, these two policies have great potential to improve diets and complement each other. So the focus of the sodium reduction targets aims to reduce the sodium content in processed foods through different targets for each food category, taking into account the technological feasibility of compliance, as I mentioned before. And the front-of-pack labeling aims to inform consumers when a food product has a high content through a general limit for all foods. And this can also, if the nutrient profile model adopted by front-of-pack labeling can inform other policies, such as school environments, marketing, etc. And I just want to quickly show this to illustrate how these policies complement each other. So this is data from the US. And this, of course, will differ by food category as they have different thresholds by a specific food category. So, but you can see here, like, this is the distribution of sodium levels of bread. The ones in red will be over the limit. This is the limit for WHO. So that will mean that these products won't be in the market anymore. And then for products that are still high in sodium, you will have front-of-pack labeling for consumers to inform healthier choices. And with that, I finish my presentation. Thank you for your attention.
Thank you so much, Nadia, for the excellent presentation and a lot of information shared. Thank you so much. So I would go over to the next presenter, and Dr. Eduardo Nielsen, who will be talking about global and regional sodium reduction target setting. And Dr. Eduardo is a biologist and a doctor in global health with over 25 years of experience in public health nutrition. He was deputy coordinator, for food and nutrition at the Ministry of Health of Brazil for 15 years and coordinated the national salt and sugar reduction strategies since 2011. In parallel, he has worked on research on food policy evaluation, especially on food and nutrition surveillance, double burden of malnutrition and diets, and non-communicable diseases, including the epidemiological and economic modeling of sodium, sugars, trans fatty acid, and ultra-processed food policies. Currently, Dr. Nielsen is a full-time researcher at the Oswaldo Cruz Foundation, also known as Pure Cruz, but still collaborates with the Ministry of Health as a scientific consultant on food reformulation, regulatory, and fiscal policies. We are really excited to have you on the call today, and despite a very short notice. So I'll hand it over to you, Dr. Eduardo, for your presentation.
Thank you very much, Joy. And I'd like to thank Nadia in behalf of the whole team for the invitation. It's an honor to be here and to share some information. And I will speak about the setting of the global sodium benchmarks by the WHO and also the regional efforts led by PAHO. Next slide, please. I will move forward because I think everyone is well aware of the impacts of sodium policies and how it is a burden to health and to economies. And this is just to reinforce what Nadia has said previously, the importance of addressing the best buys and how food reformulation targets are for sodium are one of the acknowledged strategies used by WHO. And next, please. So moving forward, I will speak about the WHO global sodium benchmarks. Next, please. I was part of the task force for both WHO and PAHO, so I can speak as a participant. And the technical experts at meetings that were led by WHO started by reviewing the outcomes of the technical consultation that preceded the meetings to set these objectives actually, and then we moved forward to revising all the results that we had from country data, and then also assessing what food categories should be prioritized in the global sodium benchmarks, because it would be based on the availability of data and all the whole technical analysis that we would be addressing. And finally, to draft the global benchmarks that was published lately, which is the cover is here at the right. Next, please. And then the group has said that we would have to think about many aspects of sodium reduction at the national level. So what agency or organizations should take the lead, if the targets should be voluntary or mandatory, the types of targets, because there are many countries that use maximum levels, but there are also countries that have been using simple averages, sales weighted averages, and percentage reduction. So what would be the best approach for us to use from the group, the possible timelines to achieve these targets, the food categories, of course, which is very important, which to set the values of the targets, and thinking about actually adding to that what would be thought in terms of dietary intake assessment, for example, by addressing the main contributors to salt in the diets. And finally, of course, we need to address the changes in sodium levels in food, and then the health impacts of the strategies. Next, please. So this is just a picture of how extensive the work was and how many countries we had the data available for working at. So 41 countries and one WHO region and one WHO sub-region participated with their own regional targets. And so it was very comprehensive in terms of different contexts around the world. Next, please. And the rationale for establishing the global benchmarks in the end that we decided would be first to compile the evidence of national and regional data, and then set the benchmarks according to maximum targets, because that would be something that would be feasible to all of the contexts that we were able to evaluate at that point. And of course, the main categories may be too broad, and there may be specificities in terms of some food products. So there was an opportunity of also setting benchmarks at the level of subcategories. And finally, that the values would be based on the lowest level for each subcategory in existing national or regional targets. And based on that, we would move forward to a case-by-case review to see, to ensure that that would be something that would be appropriate for a global benchmark, and also the feasibility that would be for applying it in different contexts. Next, please. So these are the 18 categories and almost 60 subcategories. And then some are marked because they didn't have, we weren't able to set the targets at the first moment. But we at this moment, actually, WHO is coordinating further discussions to include new targets to the global benchmarks. So it's a huge set of benchmarks that should be used by countries as a reference for their policies as well, because there's something that that's showing that sodium reduction is feasible for these products, and based on the experience of different countries in the world. And besides country representatives, some scientists, we also have food scientists as part of the expert group, so we could discuss in more depth as what would be more feasible or less feasible in terms of the alternatives. Next, please. And finally, here is how the targets are presented. So with the main category, the subcategories following the description, the global benchmarks that were set for the categories, and a little bit of the discussion on the specificities, the last column that we could have in terms of the country that was referenced and why, for example, the no benchmark was found for that category at that moment. So there's a complete description of all of the food categories that should be used by countries in their national processes. Next, please. And then I will speak about the updated PAHO regional targets, because we had previous targets before we updated them a few years ago. Next, please. And it was based on several and many works that we had in technical advisory groups led by TAHO, a consistent statement that we made for the first PAHO targets, and it said something very important, was a phase-wise approach, and that so the first targets that were set to should be revised, and that's what we did. But part of the process of revising was it was justified because many of the foods already met the 2015 targets when we first analyzed the data, and we should move forward because many countries were already setting lower targets. We had more available data on sodium monitoring, and there are other policy documents that were very important that were improving the discussions of food policy, especially for including what would be in cardiovascular disease preventions, like the PAHO nutrient profiling model, front of package labeling instructions, and also the global benchmarks set by the WHO. Next, please. And here's just a picture of the group to see that there are many people, and Nadia and I were part of the group, and we were led by Dr. Mary Lebet from the University of Toronto, which is a WHO collaborating center for nutrition policy for chronic disease prevention. And we had many meetings to discuss the steps, all of the rationale that will be made in the subcategories and what will be added. Next, please. So when we came, it's important to see how we evolved over time. In 2015, we set the first regional targets. We only have targets, national targets for 4 countries. And then, of course, we had the data from the UK as well, and very little national data on monitoring. On the other hand, in 2022, we had from 10 countries that had their targets and monitoring data that was available too. We had all of the review from the UK and the WHO targets. So that led us to have much more materials to work on and to improve our targets actually over time. Next, please. So part of it here is the rationale and overview of how it was data. We gathered all the data from the country, from the monitoring and the targets, and we set targets for 2022 and 2025 based on 2 different parameters. First, milligrams per 100 gram of product, and also on milligrams for kilocalorie, which is very important because it also addresses something about the energy density of foods, and also something that we can use according to the nutritional profile of PAHO for front of pack labeling as well. And the main objectives were to set targets for 2022 based on a 15 reduction in the median that we found from 2013 to 2015 in the levels of sodium. And then following for 2025, we would double this reduction to 30% to the same medians. Next, please. So here's just to show that the picture that we had when we first started setting the data, the targets that many of the countries have had met the regional targets, which are the middle column, and the targets they had something different at the first moment in 2015, because we also had targets that would be the lowest, the stringent targets for the region, which would be the lowest found in all countries. So in that case, we didn't have so many countries meeting it, but the main targets, which are in the middle, were met by many countries. So it was the moment to move forward and set more stringent targets for the countries, and also to add more food categories to the set as well. Next, please. So here's just an example of what we had in 2015. We only had bread products as a full category, but then and the updated targets, we subdivided it into subcategories. So according to the specificities of food groups, and especially what was found in the countries of the region. Next, please. And here's an example of how the targets were set. So we have at the left here the median and the percentile, the 25th and 75th percentiles for different categories of breads, for example. And here it's in blue with the red markings, as well as what we were set in terms of the 15% reductions for 2022 and the 30% reductions for 2025. And we also compare this data to, for example, what the target set by the USA's FDA, by the United Kingdom, and by other references that we had, so we can compare that and see the feasibility. And but because we had a longer history, that we desired to move forward as fast as possibly. Next, please. And then we have what I spoke about, the something that was new, that was also bringing, besides the milligrams per 100 gram of product, the milligram of sodium for by calories in the product, because then we could have something that could be addressed. For example, in terms of the nutritional profile of WHO, a product would be considered high in sodium in case it had over 1 milligram of sodium per 1 kilocalorie of product. So that would show that, for example, for breads, most of them are, all of them actually are 1 or more in terms of the density of sodium, in terms of the nutrient, the energy of the food. So it would be important for us to see how these policies should work together as well, so we could use both of these data. Next, please. And finally, thinking of how to move forward, we set these principles for agreeing and moving forward in terms of the products. For firstly, that the targets are agreed based on national data, and that should be kept in the future. The targets are voluntary because they're set by the Pan American Health Organization, and they're a starting point for recommended for countries to use. The governments may set different targets, include different subcategories, because it will be more specific to the countries, and they're encouraged to develop more stringent targets as well, because that, of course, for example, countries that have already existing policies should move forward in their gradual approach. They should be revised over time according to what we find in terms of movements in the whole world and in the region. And finally, it's very important to monitor and evaluate the compliance and be transparent and safeguarded of conflict of interest in all steps of the process. Next, please. And I'll end my presentation showing some data from Brazil that actually corroborates what Nadia has spoken about, and what I'm very happy to hear from Dr. Jerome from Nigeria, that a multi-strategy approach is the best one. And here's some model data from Brazil, showing firstly that mandatory targets are much more effective than voluntary targets. And as a matter of fact, we have in Brazil that front of pack nutritional warnings are very effective as well, and they complete the impact of the targets. Communication campaigns are very important as well. And finally, that Brazil has a similar situation to Nigeria, which is having a huge contribution of discretionary salt, table salt added to food. So we also are discussing the possibility of using low sodium salts as a complementary alternatives that could also have a huge impact in terms of preventing cardiovascular mortality. Thank you very much.
Thank you so much, Dr. Eduardo, for for that presentation. And it was interesting to listen to the experience in Brazil and the extensive work that went into it. Thank you so much. So we will move over to questions and answers, discussions. And so I'll open it up for everyone. If you have questions, you can raise your hand and I will call you to speak. Thank you. Okay, well, our partners are getting ready. Dr. Eduardo, I have 2 questions for you. So in Brazil, were there coordination with the food industry and the Ministry of Health regarding implementation and monitoring of the sodium reduction targets? And what would you say are the potential industry pushbacks, or where the potential industry pushbacks or influence towards successfully setting salt targets in Brazil? Thank you.
Thank you very much for the question. It's a very important point because it was something that we experienced in the country. As it was voluntary, we had a general agreement with the food industries in Brazil, with a major association of food industries that would encompass up to 80% of the food market. So it would have a huge reach, and when we said it, and I think there were both sides. We had pushbacks in terms of making the targets mandatory. Actually, as a matter of fact, still today we have voluntary targets, although we have evidence that shows that mandatory targets would be more effective. But on the other hand, the cooperation of industry was important at the first moment, because we only had the data from the UK, and we were able to discuss many of the food reformulation aspects with the food scientists and everything, and have a better knowledge of what were the roles of salt in the products, sodium in the products, and how we should move forward. And so I think there were both sides in the very end, but at the final moments, and when I left the Ministry of Health, we were actually discussing how to implement the updated PAHO targets and the WHO global benchmarks in Brazil. So I hope I'm still working with the Ministry of Health so we can still move forward. And of course, it's still challenging to work on the mandatory part. So if I had one recommendation to countries, if it can start as mandatory targets, it's much easier than converting a voluntary target into a mandatory target, because there will certainly be some pushback, and they will argue that they're already implementing things voluntarily, and there is an impact. Of course, there is, but not enough impact as we wish there were. Thank you.
Thank you so much, Dr. Eduardo. That was really good to learn.
I have one question for our local partners, Dr. Jerome. I may ask. I would like to know if there's any evidence on potential health impact of meeting sodium targets in Nigeria, or if there is any plan to do that, any conversation at the national level on that. I know there's evidence on sodium intake and the food supply, but with all this great data, we can move things to do some sort of modeling to see what would be the impact. Thanks.
Yeah, there's conversation ongoing, but I'm not aware that there's any at the moment particular focused activity looking at that specific question. I think the National Salt Study Team is a team that continues to look at various aspects, and I do not know whether their existing funding will enable them to begin to address new questions. I'll have to find out. Maybe Joy may have that information, because she's also interfacing with them quite a bit.
Thanks so much, Dr. Jerome. I want to be mindful with the time. It's already 10, but before I wanted to ask you, Eduardo, I think we have this conversation before, but what is your take on having these policies that we discussed today, salt targets and front of pack labeling, implemented together, and what's the potential benefits of it?
I think that's a great question, Nadia, and thank you for asking it. As a matter of fact, the evidence that we have shown that, as I said, their multi-strategy policies are more effective. And when we think of the targets working together with front of pack labeling, that's where there will is probably a better synergy in terms of informing the people about the context, the content of sodium in foods, uh, helping them to have healthier decisions, and it will also promote food reformulation. So it's a win-win situation, and it should be encourage countries to move forward with both together, because they don't replace each other. On the contrary, they complement each other.
Thanks so much, Eduardo. Over to you, Joy. I think we're on time.
Yes, we're on time. Let me see if we have maybe one last question from the partners.
I have one more. If we have a couple of more minutes, Dr. Jerome, we would love to hear how do you garner strong public support in Nigeria to advance with SAL targets? I know your amazing job so far, but like what will be from your experience the key things that we need to start thinking ahead to have this support, public support?
That's a multi-pronged answer that I'll provide you. And that is that in terms of getting public support, we'll have to, again, segment the country and look at how we target various segments of the country. So in terms of reaching out to the young yuppie population who are media savvy, social media savvy, of course, the best way of reaching out to them is to generate social media buzz. And we're already embarking on that journey, and it's easy to generate buzz with that target. With the rest of the population, particularly the rural population and the not so literate population, then we'll have to rely on a combination of both the use of the mainstream media, using radio, which tends to work very well, radio programs, radio jingles, radio conversation programs, live conversation programs already, because radio has more reach than any other form of media right across the country, and that way we'll be able to reach different segments of the population, particularly when some of those radio programs are programs that are conducted in the local languages of particular segments of the country, because we speak different languages in different parts of the country. You know, Nigeria is like your proverbial Tower of Babel. So even though our official language is English, people tend to communicate better and understand and adopt messages when they're shared in their local languages. Then, of course, we will need to supplement what goes on in radio with what the city population and what the key policymakers tend to focus more on, which will be live television and of course normal print media in terms of just normal reporting, editorials, columns, articles put together, so the policymakers can have better understanding, better appreciation of the challenges associated with the need for sodium reduction. And so the answer is that we'll have to use multiple strategies. There's no one single bullet that will work best, and it will all depend on which particular segments of the populace we're trying to target. And we think that the work we're doing through civil society, of course, also has a significant role to play in terms of increasing our voice and the diversity of the voice, speaking on the issues, of sodium reduction.
Thank you, Dr. Jerome. And I thank you everyone for your participation. A special thank you to Eduardo for being here. Thank you so much for your support. Thank you, Joy, and everyone. And we'll send an email with some questions that we still have pending, and have a good day.
Thank you.
Thank you.
Bye.
Bye.